In Chibuku and Palisa districts, the past 3 decades have resulted in only a small reduction in maternal and perinatal mortality despite various government interventions. Nationally, health facility deliveries have increased to 73% over the same period, according to the Ministry of Health. Despite this, many deliveries still occur in the communities and homes in Uganda. As a result, many maternal and perinatal deaths still occur at home without the knowledge of the health facilities and are most likely not captured in the health information systems. Health sector players in Palisa and Chibuku districts point out that malaria in pregnancy and urinary tract infections are the major factors contributing to the maternal and perinatal deaths. These, together with the delay in making a decision to go to the health facility, the delay in reaching the health facility, and the delay in receiving care once at the health facility, compound the problem.
Greatest cause is prematurity. That a number of our babies are born premature, and there are reasons behind this prematurity. One of the cause of premature babies or deliveries is UTI in pregnancy and malaria in pregnancy, and those are the greatest cause or underlying cause of our perinatal death.
We need also to do more work to improve on ambulance services at community level. If we would get as many as possible these tricycles, they would go a long way in easing transport from the communities to Health Center 3.
To address this and other maternal mortality challenges, Makerere University's School of Public Health, with funding from the government, started the Alarm and Response Systems project in the 2 districts in December 2019. The Ministry of Health introduced maternal death reviews in 2008 and added perinatal death reviews in 2012 to create the current maternal and perinatal death surveillance and response review protocols. They were thought of as quality improvement tools to aid in identification of and support in addressing implementation gaps, which would lead to improvements in the health system and prevent further deaths in the long run. However, this has not happened. The review has been reduced to a diagnostic tool which barely identifies the actual gaps. The Alarm and Response Systems project looked at setting up mechanisms for the implementation of the ministry's maternal and perinatal death reviews by reactivating the existing MPDSR system.
As a district, before the alarm system was introduced, though we were carrying out maternal and perinatal audits, it was not very robust, and it was lukewarm. Though initially government of Uganda had initiated systems to try to enable us carry out those perinatal and maternal audits regularly and when they occur, but for some time there was a lot of complacency among health workers, and when the alarm system came, I want to admit that we rejuvenated the maternal perinatal audits, and we established all the relevant committees at the district level and at the Health Center 4 level and other lower level health facilities. And we were able to review our performance routinely, and we, based on whatever we were getting, to routinely improve on how we are responding and making the audits. So in brief, I want to say yes, there has been some change, a positive change, whereby a new culture was introduced in us and we embraced it in totality to be able to effectively reduce on the number of mothers dying during delivery, and even to reduce on the number of children who are born when they have passed on, or those who are born but shortly after that they die within a week or 2.
During implementation, it was discovered by stakeholders that the neonatal unit at Palliser District Hospital that would help to save the lives of preterm babies is poorly facilitated and lacking incubators.
We are sharing most of the things with the other wards, yet in this unit, we need the concentrator to be there full time.
Our neonatal unit, we are still struggling. I think we have a capacity of, we only have 3 KMC beds. The malaria and the UTI that is being reflected as the main cause of our death is actually giving us premature labor. So eventually we are having a lot of preterm babies, and we all know that preterm babies still need a lot of external support to be able to survive. So we are not achieving that because we also have issues with our incubators. We don't have enough. Usually we have stockouts of essential drugs, which we are requesting. If we address all that, we shall improve on our performance. We also previously had a challenge with the staffing, in that the neonatal unit was being run by the midwife, who most times is running the labor suite and then the postnatal. It became really a very big workload. What we did is that recently we've deployed different staff who are stationed to only work at the neonatal unit.
Efforts to rectify maternal and neonatal death reviews have largely focused on the health sector and to some extent on women as a group affected. Rarely have the key stakeholders such as local government leaders, media, community leaders, and men been engaged actively in solving this problem. This has largely affected the outcomes reflected on maternal and child health. Dr. Elizabeth Ekirapa Kiracho from Makerere University School of Public Health, also the lead project investigator, told NBS Television that they were successful in enabling health workers to make maternal and prenatal audits by developing an approach where various stakeholders participated in the review of deaths.
We have realized that there are certain things that lead to maternal and newborn deaths that could be addressed. For example, in some cases, health workers do not have the skills that they require to resuscitate a newborn. In some cases, they are not able to identify early enough women who are having problems during delivery. Hence, they have delayed or late referrals. We've seen that if you identify those issues, you can put in place appropriate interventions. For example, to address the skills, we conducted a training of health workers in Chibuku and Palliser, and we're able to identify with them some of the challenges that they face and to equip them with the skills that they require to handle that. So training and on-job support supervision and continuing mentorship is one intervention that can help to address this challenge. The districts are also responding to some of the other challenges, like lack of blood was noted to be a problem, and so the districts have purposed to ensure that they budget money for collecting blood from Mbale, which is the regional center where they get blood from.
Basically, there are community issues, and those community issues, you know very well, it is the communities that dictate whether one is supposed to go to another level of care. So we, in the alarm system, we were able to engage the communities, and in the communities, the opinion leaders and local leaders. So we empower them with knowledge to make sure that they are able to offer the advice to these mothers who are at risk of getting issues during delivery. And I want to report that we rejuvenated the community system, and in addition to that, we were also able to deploy some ambulance, motorcycle ambulances in those communities that are hard to reach. Then too, we were also able to address the second cause of maternal and perinatal death, that is at health facility. We were able to empower the health workers with knowledge and skill. We trained a number of them. We attached close to 25 health midwives at Mbale Regional Referral in the previous year. Furthermore, we also had a training in Chibuku, I think more than 3 trainings in Chibuku district, where we invited senior obstetricians to come and mentor our staff locally. And the aim was to empower the midwives and healthcare providers to make appropriate decisions and offer a service where it is needed.
About 3 years ago, we were having about 45 out of 100 mothers delivering with us. But as I talk now, we stand at 71. That means at least a good number of our pregnant mothers are delivering in the facility. Through our VHTs, we have given them registers, and we have tried to give them we have tried to give to format them such that they are able to register for us all pregnant mothers in their villages. Actually, we have gone ahead. We don't only require them to register pregnant mothers, but we want them to register pregnant mothers or to identify pregnant mothers in their first trimester, such that they come for antenatal. And that has greatly improved the attendance.
Also, we were able to as well empower the medical officers. In case a mother is found to need a cesarean section, we were able to share with them their role in addressing or in coming up with solutions to address maternal and perinatal death. So we have strengthened the duty roster system, whereby at least every hour of the day there is a doctor who is available on call, and whenever there is an incident where a mother is in need of a service of a doctor, we are always in touch with them, and we pick them and they come and respond. And lastly, we also tried to improve on the ambulance systems from the communities to Health Center 3, and from Health Center 3 to Health Center 4, and from Health Center 4 to regional referral.
It is expected that improved audits will greatly reduce the high maternal and perinatal deaths in the 2 districts after closure of the project.